My topic today is about non-operative management of splenic trauma. I was asked why should I present about non-operative management as I'm a surgeon, and I think that it's important to know when to operate, but it's more important to know when not to operate. So a little bit of a history. What is the non-operative management of splenic trauma? It's usually about blunt injuries, and it has become the standard of care. It's highly successful with failure rates ranging between 2 and 31%, and currently one of the cornerstones of non-operative management includes splenic artery embolization. In 1882, Ruse, in his textbook, A System of Surgery, mentions that surgery about splenic trauma should be performed only when necessary. This is the earliest mention of non-operative management. In 1968, Upadhyaya observed that often children with splenic injuries show signs of improvement even without surgery. And in 1971, Douglas and Simpson described 32 cases of children with splenic trauma that were managed conservatively, and 25 of them did not require surgery at all. Actually, the non-operative management of splenic trauma involves from the SOS movement, which is Save Our Spleens. What are the standard criteria for non-operative management? Hemodynamically stable patients or a readily stabilizable one, lack of rebound or guarding on examination, blood transfusion of less than 4 units of packed red blood cells, no lack of consciousness, usually patients that are less than 55 years of age respond better, and also imagically documented splenic injury. The absolute indication for emergency laparotomy is only hemodynamically unstable patients. Let's go to the trauma guidelines. What do they recommend? Even in these guidelines that were first published in 2012, and some of them are still considered current despite the time difference. It is widely accepted that non-operative management should be considered in appropriate patients, and it is validated through the ACS Trauma Quality Improvement Program that the non-operative management is beneficial. They also recommend that solid organ should be preserved when appropriate and when possible. The name of the game, according to the trauma guidelines, is damage control resuscitation. They favor transfusion of blood products over crystalloids in a ratio of 1:1:1 or 2:1:1, with emphasis on the use of packed red blood cells. The success of NOM is different in different grades of injury, and it ranges between 61 and 97%. The benefits of non-operative management include reduced rates of overwhelming post-splenectomy sepsis that can be observed in 0.5% of all of traumatic splenectomies, but it can go over 20 in elective splenectomies for hematologic disorders. Also, it reduces the complications of abdominal surgery, early or late. The splenic artery embolization is a cornerstone for a successful non-operative management, and recent protocols include its use in them. What are the indications for splenic artery embolization? A grade 3, 4, or 5 splenic injury, visible lesions on the initial CT scan, active bleeding upon CT scan, or unexpected decrease in hemoglobin levels. The first agent that was used for embolization was the Gelfol, and after that temporary bowel occlusion, and they were initially used for hemostatic purposes prior splenectomy, but later on they took over the surgery as a whole. The embolization can be proximal, selective, or combined. And the signs of failure of the non-operative management include hemodynamical instability, usually in patients that are over 55 years of age, transfusion of more than 4 units of packed red blood cells, persistent leukocytosis, onset or abbreviation of peritoneal irritation or guarding, worsening imaging signs, and intra-abdominal compartment syndrome defined as pressure over 20 millimeters of water. So this is the latest case that we treated non-operatively at our hospital. It was a referred patient that had a CT scan and data for splenic rupture with hemoperitoneum. He was referred to us on the following day because the injury occurred in the evening and there was a little bit of a delay with the transfer. It was a male patient, 69 years of age. He was obese. When he presented, he claimed to be 150 kilograms, but later on when we weighted him on the bed showed 162 kilograms. He had a chronic kidney disease with creatinine levels around 380 to 400. That's the normal levels that he was presenting when at home. He had arterial hypertension and diabetes. The patient is post-operative for a sleeve gastrectomy performed 1 year prior to this, and he weighed 190 kilograms. His hemoglobin level was 74 upon referral, but later in our ER department, the one that we got was 58. His blood pressure was 110/70. He was covered in cold sweat, had mild abdominal pain, but no signs of guarding, no deviation in consciousness, and he had received 1 unit of packed red blood cells. This is the initial ultrasound scan that we managed to obtain in the ER department. Not the best image, but for a 160 kilograms patient, it's hard. This is the CT scan that we performed with the visible hematoma and hemoperitoneum and contrast from the previous imaging study. But we didn't have the previous imaging study and we had to have a reference point for future scans. This is the embolization procedure that we undertook. This is the initial angiography. It shows a slight brush right here that's indicative of bleeding. And we performed embolization. This is the catheterization of the artery with a little bit of contrast as a guide. And reaching the higher of the spleen. And this is the result after embolization of the artery. You can see retention of previously used contrast and the cutoff where the embolization has been performed proximally. This is the ultrasound with a power Doppler after the procedure. You can clearly see the margin. And there are no signs of power Doppler signals in the spleen vessels. So after the procedure, the patient presented with a slight increase in creatinine levels, but it was managed conservatively and almost reached normal levels before the procedure prior to discharge. A total of 4 units of packed red blood cells were transfused and the hemoglobin level reached almost 90. There is a reduction in the leukocytes from the initial presentation in the ER from 33K to 16 in 4 days after the procedure. There was a resolution of abdominal pain within the first 24 hours after the procedure, and the patient was hemodynamically stable almost immediately after the procedure in a couple of hours. He was discharged 12 days after the splenic arterial embolization. On follow-up, he presented 1 month because of control blood tests that showed an increase in creatinine levels and worsening kidney function. Those are his initial parameters. He was started on dialysis. His creatinine level decreased in 4 days to levels that were comparable to those pre-procedural, but on the 4th day he had a massive bleeding from his upper GI and a really big fall from hemoglobin from 90 to 50. He was transferred to the ICU, but on the way to the ICU he had a cardiac arrest, and we had to start CPR, and it was actually in the elevator that we started the CPR. After intubation and resuscitation, an upper GI endoscopy was performed, and it was confirmed that this is from a gastric ulcer, and unfortunately 3 days after the resuscitation the patient died. Thank you for your attention, and I would like to begin the vote.